It's the 28th of November, 2025. This is the Room Now podcast. Hi, I'm Jack Cush with Room Now. This week on the podcast, FDA resurrections, seasonal worsening of fibromyalgia, and in psoriatic arthritis, it's not responding. What do? Do you fight, switch, or swap? Let's begin with a national health survey that gives you some data about disability and arthritis in the United States. This is the 2023 NHIS survey, and they looked at adults in the United States between the ages of 18 and 64. And specifically, they studied the number of people who have work limitations due to arthritis. Arthritis attributable work limitations. What do you think the number is? You know the numbers of arthritis in the United States, like 57 million, that sort of thing. Most recent estimates. This number, I think, is an astronomical 38.8%. And oh, by the way, that's no different than it was 4 years ago. These numbers are even higher in certain subgroups. Hispanics, 50%. American Indians and Alaskan Native Americans, 56%. The people disabled, not surprising, 62%. But veterans, 52%. It's a long report. It's a good report. It really does say that what we do is a major part of healthcare delivery. And the numbers, at least 25% of people present to outpatient medicine with a musculoskeletal complaint. At least 50% will, in the course of an outpatient visit, be found to have a musculoskeletal problem, and it is the number one cause of disability in the United States. Good news, Zantac is back. Ranitidine was removed from the market. What year was that? It was like 2019, I think I wrote about it on Room Now. It was taken off of the market because of a contaminant, an impurity issue with NMDA. NMDA at the time was touted as being maybe carcinogenic. It's an uncommon food additive. It's an uncommon contaminant that was found. And then it's been studied really since 2019. It went back on the market because the manufacturers, and these are many generic manufacturers, have basically approved the reformulated version. And it was thought that NMDA was maybe posing a cancer risk, but also tended to change the, the durability of the drug or the pharmacokinetics of the drug as well. Anyway, it's back on the market. I don't know if you're a big prescriber of Zantac, an H2 blocker. It was not too long ago, the number one anti-acid drug in the United States before PPIs took over. I think it merits consideration again, and now you can add that to the other H2 blockers like PsA and others. This reminds me of many drugs that have taken us off the market. There have been most recently propoxyphene or Darvon as being risky but not really effective. I think the most notable one, and since this is Turkey Week, I'm going to bring up L-tryptophan. L-tryptophan, during my fellowship, was a big drug that you would use to treat as an adjunctive agent in depression, but more importantly, because it drove serotonin levels, it was also good at sleep. And so it was a natural sort of sleep aid, if you would. 500 milligram tablets, you could take a few at night, and it worked very well. It was taken off the market in 1989 because of reported cases of the eosinophil myalgia syndrome. And what happened was that it wasn't from the tryptophan. It was due to an impurity in the manufacture of tryptophan. And it actually went back on the market in 2005. I must say I haven't used a lot of L-tryptophan since. I have more patients coming to me on it. I think it's a perfectly safe and reasonable natural product. I like valerian root as well as a sleep aid. I think melatonin is a gigantic waste of time. It doesn't work at sleep. It doesn't put people to sleep. It doesn't keep people asleep. It's good for time travelers, people going over time zones, and people who go back to the future, like Michael J. Fox did. It's good at that, but otherwise it's useless. But I think tryptophan and valerian root, I would endorse those. Anyway, for the right dose, look it up. I think someone should study this again because it was such a a mainstay drug back in the late 80s. Some gout reports that are interesting. Colchicine, when used in gout, has been shown to prevent the need for total joint arthroplasty. This is a study of over nearly 32,000 people starting colchicine, followed for almost 5 years, and they showed a hazard ratio of 0.88, a 12% reduced risk of joint replacement, and a 23% lower risk of joint replacement for hip and knee replacements. And I think these are significant. I mean, the point is that colchicine is good at preventing attacks, and repeated attacks will get you more damage, and more damage will get you more surgery. So we know colchicine, we talked about colchicine and its cardiovascular benefits. It clearly has an articular benefit, much more certainly even than cardiovascular. Interesting cardiac study looked at an echo study of 200 plus patients with hyperuricemia, half having gout, the other half having asymptomatic hyperuricemia. And they showed that when you compared gout patients to the asymptomatic hyperuricemics, gout patients had significantly worse diastolic dysfunction than did the hyperuricemic patients alone. They also, patients with gout had lower ejection fractions, 60% versus 65%, 5% better. The diastolic dysfunction was 31% versus 11% gout versus hyperuricemia. So again, I think that this gives us a good reason to worry about cardiovascular disease in patients with uncontrolled inflammation, recurrent bouts of inflammation, and that's not good for you. And that is probably the inflammation and maybe not the uric acid itself that drives that cardiovascular risk. Nonetheless, I think this is a reminder that we probably need to do cardiovascular monitoring in our patients with gout, if not hyperuricemia. A few studies on myositis, 2,280 patients with either dermatomyositis and polymyositis looked at those who were treated with short-term corticosteroids, less than 3 months, or long-term corticosteroids, more than 3 months. And they showed that compared to short-term use, those that were on long-term exposure of glucocorticoids had a significantly higher risk, an 80% higher risk of heart failure. That was surprising to me. Not surprising, a doubling of the risk of osteoporosis, and a fourfold higher risk of hospital admissions related to polymyositis or dermatomyositis, and obviously a significantly higher cost of care, all associated with longer-term steroid use. I don't know about you. You know, we talk a lot about steroids, the hazards of steroids. We worry about it in lupus, where we use high-dose steroids, or vasculitis. I see more disasters in polymyositis, dermatomyositis. And I think it's because we often don't think of it as being as dangerous in that condition, when in fact it is. I've seen patients get avascular necrosis, many of them with just 4 months of high-dose steroids. It happens. And so we got to worry about it in inflammatory myositis patients, as well as our others who we use high-dose steroids in. 2 reports on fibromyalgia. An Italian fibromyalgia registry did a study. Why they would do this, I don't know, but it's kind of brilliant. They studied 2,614 patients, and they looked at seasonal changes in pain using a number of different fibromyalgia tools and tools for widespread pain index, etc. And they found that using the fibromyalgia assessment tools and the WPI and FAS, they showed that autumn was associated with significant worsening of pain in fibromyalgia. That's autumn compared to summer and autumn compared to winter. Now, take all the other 4-season combinations, there's no differences in pain. It's year-round pain. It's widespread pain, is it not? But why is it worse in autumn? Isn't that interesting? They pointed out that in Crohn's patients and IBD patients have worse endoscopic scores in autumn compared to summer. They pointed out that there are seasonal variations in acute phase reactants in some patients. I think the easy answer here is that you do better in summer because there's more holidays, there's more activity because the weather is good, and that starts to then change during the fall. And maybe autumn is when things go to hell in a handbasket, as they say. I thought that was interesting. Another interesting study I wouldn't have thought. I mean, we certainly know that if you have fibromyalgia patients in your clinical trial, it's going to ruin your data because it's going to skew pain scores, function scores, et cetera. A lot of scores that we do, rapid, CDI, I do the GAS score, -28, they're all going to be higher in patients with fibromyalgia. In this study of 58 patients, they did usual fibromyalgia indices, the FIQ, the symptom severity score, and they did the BASDI. And they showed that when the BASDI was abnormal and elevated at 4 points or higher, that was seen in 91% of fibromyalgia patients and only 13% of controls. BASDI score associated or correlated with the pain, fatigue, and stiffness in the FIQ, and also in the symptom severity scores, and those are all highly significant. Point being, one, fibromyalgia will drive your index of disease activity up. Two, may not be a bad idea to actually use the 5 questions that you ask in the BASDI that can be used in fibromyalgia as an outcome measure. Interesting. Psoriasis is in the news this week. The global burden of psoriasis increased from 1990 to 2021, a 31-year period. It went from 60 to 70 per 57 to 61 per 1,000 persons, a 10% increase in that 30-year period. So a slow, modest increase, but psoriasis is going up, and of course that may go up for a lot of reasons. We don't know the pathogenesis. We do know obesity is involved. Obesity's certainly gone up, a lot higher than that. The risk was highest in North America and Western Europe. And they did show, interestingly, that the peak incidence of psoriasis was ages 40 to 70, and the risk of psoriasis was highest with higher incomes. So medium to high incomes and high incomes had a much higher risk of developing psoriasis compared to low incomes. It's really quite dramatic if you look at the graphs. Leahy Eder from Toronto published a really nice paper about the obesity inflammation axis in psoriatic disease, showing that obesity is, we know, associated with less remissions and poorer drug responses. The etiology of that is discussed in the paper, and possibly due to the pro-inflammatory adipokines, biomechanical stress, which is a big factor in psoriatic disease, meaning psoriatic disease is higher in people who have physical blue-collar employment. Biomechanical stress is not just being obese, but obesity certainly adds to it. And then a lot in the literature and a lot of discussion amongst the mavens about gut dysbiosis. So all this, of course, is backed up by the data showing clearly in psoriasis, more so than any other disease, that weight loss will improve outcomes and improve response to therapy. Another psoriatic trial of what happens, and this is from Artie Cavanaugh and colleagues, when you're a first-line non-responder to a TNF inhibitor with psoriatic arthritis. 452 patients were studied. About 2/3 of them either cycled to another TNF, cyclers, or 1/3, 177, swapped to an IL-17 inhibitor. They showed that swapping was better than cycling. So retention being a measure, retention at 1 year, 78% versus 68%. If you swapped, you did better than if you cycled. So at 36 months or 3 years, it was 60% versus 40%, favoring those who swapped. Treatment failure was predicted by cycling, disease activity, year of treatment, having axial disease or mixed axial and peripheral involvement. Lastly, I think I like this report about PMR, and PMR can look like, can be misdiagnosed, and could actually be due to parvovirus B19 viral infection. 77 patients referred to rheumatology for possible PMR, and it turned out that 7% of them, or 5 of them, had PMR features, met PMR criteria. 5 out of 5 having bilateral shoulder and neck pain, prolonged AM stiffness, fever is high, acute phase reactants. Interestingly, these people did not have lower girdle or hip pain. Interestingly, they were almost all male.
and they were also younger. So when you have atypical PMR, they're too young. They're not. I mean, you got to in my opinion, you have to be 70 or 80 to have PMR. If it's 60, I'm worried. If it's 50, I'm not making the diagnosis. Although I have one in my career that was 51 and clearly had PMR. Interestingly, also that in this cohort of few patients, 5 total out of the 77, that they were not rheumatoid. I'm sorry, none of them were rheumatoid factor or CCP positive. There was 2 reports this week that I posted about perioperative DMARD use in patients who were undergoing arthroplasty. One, a Korean study of 34 patients, half continued their therapy, half modified therapy, and they modified it in accordance with the 2017 ACR and American Association of Hip and Knee Orthopedic Surgeons, the guideline authored by Susan Goodman, an ACR guideline that says that you continue conventional DMARDs throughout surgery. You do not stop. This is the guideline. And that if you're on a biologic, that you hold it for no less than 2 weeks or you half the dose, right? So that was the guideline. Let me see. And again, the biologics that they use, the biologics they continue were methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. The biologics that they altered for a short period, they hold for 1 dosing cycle, and they restarted within 2 weeks of surgery completion, provided there was no contraindication. That applied to golimumab, adalimumab, etanercept, abatacept, infliximab, and certolizumab, largely TNF inhibitors with abatacept thrown in. So that worked. It also worked in another study from Japan, much larger number, and it worked as far as at 2 years, the endpoints being surgery and orthopedic scores were the same, no difference. Right. Another retrospective study from Japan looked at 1,953 RA patients, all older. A third of them were in low disease activity state, and 20% were in remission. And they found no differences between continuing or stopping the DMARD therapy as far as going, during the perioperative period. No differences in wound healing, infection, and mortality. However, if you did discontinue the drug, they had more disease flare-ups. These are the kind of things that we need to hear about. And you're going to hear about it at Room Now Live, February 7th and 8th. Susan Goodman is one of our featured speakers. Susan Goodman is on the faculty at Hospital for Special Surgery. She led this effort with the Orthopedic Association to define what we should do in the perioperative period. And that's exactly what she's going to talk about in her half-hour address on Saturday morning, February 7th. You can go to roomnow.live to register. I hope you'll be there. Also, if you haven't seen our replays of Room Now Live 2025, we ran them in the last 4 weeks. They're on the website. They're on YouTube. You can see what happened as far as the sessions we had in 2025. You'll see those. You'll want to go to 2026. We had, again, replays of RA, vasculitis, psoriatic arthritis, and the last one was on spondylitis. So hope you enjoyed that. We'll see you next week. Go to roomnow.live to register.